All right. Well, good morning, everybody. Thanks for joining us on Grand Rounds. We'll try to get started on time today. So it is my pleasure to introduce Elliot Stein, who, as many of you here today know, is neither Cooper Kersey nor Connor Tice. So Elliot grew up in Tampa, Florida, and it would give me great pleasure to stand up here and regale you all with Florida man stories from Elliot's youth. But you dig a little deeper into his CV, and you see he is anything but your prototypical Florida man. CV is actually quite intimidating. He graduated magna cum laude from Harvard and then went to the University of Pennsylvania for medical school before going to Vanderbilt, where he got his medical degree, and then came out here to the University of Washington for his cardiology fellowship, where he's excelled. And when you look at his CV, it looks a lot more like the CV of a junior faculty member going up for promotion than it does a cardiology fellow graduating from his training. Oftentimes, you have to sort of stretch these portions out to figure out what you're going to say about someone who, like many of us, went to college and med school and then residency and now here as a cardiology fellow. But Elliot is anything but. He has 14 papers, 4 textbook chapters, and a whole bunch of abstracts and national talks and oral presentations. He's first authored papers in JAHA, twice for Circ CVI. He has second authorship for JACC, Clinical Electrophysiology, and Circ CQO. A really, really impressive track record. When I was graduating from cardiology fellowship, I had 1 second author abstract and a rejected review article on coarctation. So, and it was a rejected solicited review article on coarctation, which is an incredible accomplishment. So really, really impressive work. Over the course of the year, I've had the joy of working with Elliot in clinic on Wednesday afternoons, and he's been great to work with. He's committed to patient care. He connects really well with the patients. But the thing that really comes through when you work with him is this is just a man who has chosen the right career path in life. He loves medicine. He enjoys what he does. And each day when he's there, it feels like he's doing what his calling was. So if you've ever been in the Echo Lab with him, you've seen these giant bags of raw almonds or raw pecans or big jugs of stuff that I can only imagine are like wheatgrass or something repulsive like that. And so you probably have a sense that he cares more about the non-pharmacologic and the non-industry sponsored tickets towards health. And that's what he's going to talk to us about today, about longevity and living to 100, which frankly sounds completely exhausting, but I'm sure is appealing to some people in the room, and will guide us through what we can be doing in our life to help us live long, healthy lives. All right. Thank you, Elliot.
Thank you, Dr. Krieger. I'd like to point out that you've sampled a cashew on more than one occasion in clinic. Thank you so much for coming today. I'm going to be talking to you about longevity medicine and hopefully relating it to our work as cardiologists. I have one financial disclosure. I own a tiny amount of stock in Eli Lilly, and they make GLP-1 receptor agonists and SGLT2 inhibitors, which are being studied as potential longevity agents. I will be talking about none of those drugs today. I want to start with this image of a man named Mike Fremont. He's next to his wife, Marilyn, and he is 100 years old in this photo. He's currently 103, and he holds the world record for marathons, best time in marathons for 90 and 91-year-olds. This is Mike when he was in his 90s. This is Mike when he was in his 80s, and I promise I have no more pictures of Mike to share with you. But the point of all this is to say that Mike doesn't look like an 80-year-old when he's in his 80s, and he doesn't look like a 90-year-old in his 90s. And as Dr. Krieger perfectly just set me up right now, many of us in this room don't want to live to our 90s or our 100s or 110s. And that's largely because we associate these decades with severe debility, deconditioning, cognitive decline, being a burden on our families, and really not being able to accomplish any of our ADLs or IADLs. And so from this concept, from looking at people who are centenarians like Mike, is one of the most inspiring things that we look at when we're talking about longevity. How do we make our later decades feel more like our earlier decades? The quest for longevity and really immortality has spanned all of human history. So this is Emperor Qin, a Chinese emperor from the 3rd century, and he obsesses over finding an elixir of life. And he finds one candidate compound, but unfortunately, it is containing a lot of mercury, and he perishes from this. And there are countless other examples throughout history of people doing dangerous things to extend their life. The moribund Pope Innocent VIII was injected with the blood of children in order to try and gain immortality. This obviously did not work. And in fact, depressingly, the only immortal thing we've created as human beings is cancer. This is an image of a dividing HeLa cell, which is the first tissue cultured human cell line that is immortal. The study of longevity has really regained a renaissance, I would say, over the last several decades, and has become much more popular among lay people, and is also undergoing a lot more scientific study than in previous decades. The term longevity really comprises two concepts, and that is lifespan and health span. Lifespan is something all of us deal with every day. We're very familiar with it. We know how to measure it. It's measured in survival and all-cause death. It's already an endpoint in our clinical trials. Health span's a little bit harder to define and also harder to measure. So it's things like mobility, autonomy, functionality, resilience, and the ability to engage with the world. We can measure this through some clinical instruments like a 6-minute walk distance, understanding what a patient's, what ADLs they're able to accomplish, and their ability to remain free from injury and free from hospitalization. We also know that patients want quality over quantity. So this was a study of 100 subjects with heart failure, most of whom NYHA 2 to 3, and were surveyed, and 61% of them indicated they would rather trade some of their remaining time on Earth for more quality. And you can see that the willingness to trade time increases based on NT-proBNP, suggesting that the sicker you are, the more you want quality and the less you want time. And I think this is a really important point, because it's not just asking a young person, would you rather have time or quality? It's, would you rather trade some of the rest of your life for more quality? And people say yes. But it's not like we're winning the war on lifespan. It's not like we just need to improve health span and we're winning the war on lifespan. We all know that, unfortunately, ischemic heart disease is still the #1 killer, despite all of our amazing innovations and advancements. And why is this the case? Well, we've discovered amazing procedure interventions that are really, really good, but they're typically reactionary. Pharmacologic secondary prevention also works, but maybe too little, too late. Disease is often discovered very advanced and complex. Heart attack prediction and prophylaxis has so far been disappointing, though there have been some advancements in recent trials in this area. When we do workups for early coronary artery disease, I don't know about you, but I'm always terribly disappointed with what that workup consists of. It's an Lp(a), a CRP, and a family history. 2 of the 3 of those things we can do nothing about. And as we all know, we deal with this every day. Detection of preclinical ASCVD is very challenging, and also unclear what we do when we detect a very young preclinical ASCVD. And so one of the only things we kind of have in our toolbox that we think can make a difference before such detection occurs is lifestyle measures. And so this is the Life's Essential 8, which is published by the AHA. And I think all of you are probably familiar with this. It talks about methods to improve sleep, reducing nicotine exposure, reducing blood pressure, blood cholesterol, diet and physical activity, blood sugar, and weight. And I would love to talk to you about all of these things today, but there's simply just not the time for that. And I'll also add that there are a lot of topics that are related to longevity that are not covered by the Life's Essential 8, like the impact of psychological health, social networking and connectedness, early detection of disease like cancer, also knowing your genotype and whether you're at risk for something like Alzheimer's disease. What is the relationship between socioeconomic status and preventive measures? Is there any impact of fasting or of practicing mindfulness meditation on longevity? What is the impact of the genetic lottery efforts to improve lifespan and health span? Are there any drugs that can increase our lifespan or health span? And then what is the role of supplements and vitamins in this space? And the list goes on and on. I'd like to highlight that we know comparatively little about longevity. So why is this? How is it that we have managed to crimp a valve onto a catheter and can put it into someone's heart through their leg, but we don't we're still arguing about what to eat and how much exercise to do. The reason is because it's really hard to study longevity. There's a long time horizon to detect events. There's generally a low event rate, especially in healthy young individuals. There's a lot of interactions of the variables in question. So for example, if you're testing the impact of exercise, but exercise also acts upon sleep, and sleep also independently acts upon lifespan, this can be problematic. We use problematic instruments like food diary questionnaires, which are known to be very inaccurate. They are difficult to control. So for example, if I want to test whether olive oil may extend lifespan and I give one group olive oil, I'm also increasing the amount of calories that they receive, and I have to do something about that. I might have to give a control group an isocaloric substance, but that may also have deleterious health effects. There's limited blinding both of the experimenters and the subjects. These trials are very expensive. You can imagine if I want to do a diet study where I control all of the food that patients receive for a significant amount of time, that can be a very expensive trial to run. We have animal models, and they are of some utility. However, they have highly different metabolisms, lifespans, sleep cycles, et cetera, and makes cross-applicability a little challenging. There's also minimal industry money or intellectual property to be had. And historically, the NIH funds translational or basic science way more than it does prevention. There's no CPT code for longevity interventions. There's high industry special interests, like from the smoking industry. And it's just not cool. This is not what we're debating in the hallway. It's low tech. It's not in vogue. And I also want to highlight that when we do longevity-based studies, they can often lead to poor guidance. So for example, during the heyday of the Mediterranean diet, when we noticed that populations in Spain, Italy, and Greece live longer than age-matched and similar controls in other populations, and we studied what they ate and saw that they have a diet consisting of seeds and nuts and lean fish and greens and also red wine. And we saw that they live longer. We started to recommend red wine to patients. And we also went one step further and tried to isolate what was this compound in red wine that was extending lifespan, and thought it was resveratrol and made it into a pill. And it turns out that taking exogenous resveratrol doesn't do anything for your lifespan, and that any amount of alcohol is toxic. There are doses of alcohol that don't really do anything to your longevity, but none of it is good for you, and actually has recently led to the US government's decision to put a label on alcohol-containing products that say that they cause cancer, which I think is a good move. The other thing is we just don't talk about prevention. So this was a study of 115 routine primary care telemed visits, and 66% of them did talk about diet and exercise and activity, but only for 90 seconds. And then the patient surprisingly initiated 60% of diet and 49% of activity discussions. And about 60% of those discussions had no recommendations given at the end of the conversation. 30% of those that did have a recommendation, the recommendation was try to exercise. And physicians knew they were being recorded during this study. So I just want to double click for a second on this try to exercise thing. Imagine if we saw a heart failure patient and we said, try to take goal-directed medical therapy. The patient would say, what is that? Why is it good for me? What's the dose? What's the drug name? How am I going to know if we should increase the dose? And what are the side effects? And I think this is how we should approach our lifestyle and longevity recommendations to patients. The other thing is we are really unprepared to talk about this as a field. So this was a study from 2010 of 72 medical schools, and only 10% of med school deans thought that graduates were competent to even provide an exercise prescription. And despite that, only 6% of medical schools had mandatory exercise curricula, which really suggests to me that we simply don't care whether or not our graduates can provide such a prescription. So the goal of today really is to try and go back to medical school and reverse that a little bit. And my goal by the end of this lecture is that we all really gain a good understanding of how important one topic in longevity really is and how exactly we should try and motivate our patients to exercise more. I picked exercise over the other components of the essential 8 of longevity because I think that A, it has the best evidence and potentially the most beneficial impact. and B, potentially the area where a lot of our patients do absolutely none of it. If you look at something like sleep, a lot of people get inadequate sleep, but they are forced to sleep at some point, whereas exercise, you can live in today's world and really never lift a finger and survive. So I want to begin with the concept of fitness. And fitness is one of two main things, which is cardiorespiratory and strength. When we talk about exercise, 76% of Americans inadequately exercise. 31% meet muscle strengthening guidelines, and a little bit higher of a fraction, 46% meet aerobic guidelines, but 46% meet neither. And you can see that this finding is true across sexes and across ages as well. Just how good is exercise? It's really hard to say, honestly. There are many randomized controlled trials looking at exercise type and duration versus usual care, and no single RCT has shown a mortality benefit. And the reason for this is the reasons we just discussed about why longevity studies are so hard to run. But of course, we do have numerous high-quality observational studies that independently relate exercise inversely with all-cause death and positively with quality of life. So when we're using observational studies to imply causality, we need to know what the possible mechanism of action of the intervention is. So exercise has a multitude of pleiotropic effects on the human body. The first is that it reduces inflammation, and particularly something called inflammaging. We know that one of the main instigators of the aging process is a certain pattern of inflammation, and it's been shown that exercise reduces certain interleukins that are strongly associated with the aging process. It also is involved in protein cleanups. There's plenty of proteins in your cells that are tagged for degradation, but don't actually undergo degradation until there's some stimulus for them to do so. These proteins that are degraded may wreak havoc on the cell and introduce DNA damage, lead to oncogenesis, and so on. And exercise stimulates the ubiquitin-mediated protein degradation mechanism to ensue. We also know that exercise can improve cognition. It's one of the only interventions in Alzheimer's disease to improve cognition. It leads to mitochondrial biogenesis. It improves body composition by decreasing visceral fat mass and improving muscle mass. It can improve sleep. It can improve glucose homeostasis. It suppresses tumors, improves cholesterol trafficking, increases stem cells available to the body for repair. It also leads to angiogenesis. We see this quite often when we refer patients with intractable angina to cardiac rehab, and they come back and they say their angina is better. We think this effect may be mediated through recruitment of coronary arteries. It leads to improved endothelial function, improved microbiome. It's an antithrombotic, improved bone density. It helps prevent injury by improving things like balance. And when injuries do occur, it promotes resilience. If patients need surgery, we all know that they recover better and faster if they go into the surgery being less frail. It also leads to vasodilation, which may explain its beneficial blood pressure effects. And it promotes immunity. And I find this pretty interesting because it decreases total body inflammation, and it suggests that the effect of exercise is quite nuanced. And if we contrast this with the hallmarks of aging, and particularly looking at this red beige circle, and you can see the cellular mechanisms of aging, they almost are direct opposites from the benefits of exercise. And so I think there's a really good mechanism here for the way that exercise might inhibit aging. So let's talk about cardiorespiratory fitness, which is what most of us think about when we think about a fit individual and someone who exercises. And a lot of this is review, but just to get on the same page about everything, when we're measuring fitness, we talk about things like VO2, which is how much oxygen is consumed by a person per minute, and it is a measure of circulatory, muscular, and respiratory efficiency. VO2 max is the amount of oxygen consumed at peak exercise, and the all-important indexed VO2 max is the amount of oxygen consumed per kilogram at peak exercise. A metabolic equivalent, or MET, is defined as one MET is 3.5 milliliters of oxygen per kilogram per minute. So that's the resting metabolic rate, and any number of METs that is higher than one is simply a ratio of how much higher your metabolic rate is compared to the resting. METs are always an estimate because to actually measure METs, you would need to know a patient's VO2, and we often don't know that when we're assessing exercise. Cardiorespiratory fitness is expressed in VO2 max or in peak METs. I think it's important to know generally how many METs a patient is doing when they tell you what activity they're doing. They're obviously not going to tell you the number of METs. So what you see in the green box here is what's considered to be moderate exercise, and anything else here is considered to be vigorous exercise. A lot of patients don't do traditional exercise like you see here. They do things like tidying up the house, washing dishes, gardening, scrubbing the floor. And these things are also all exercise because they're above the resting metabolic rate, and we should be able to convert them into a metabolic equivalent. Okay. So here's our first study of fitness, excuse me. So the conclusion of this study essentially is that peak METs classifies risk of death at all ages. And there are many such similar studies, and I'm just going to highlight this one because it's very large and it was very recent and I think very well done. So this was of 750,000 US veterans aged 30 to 95 years with a mean age of 60 who happened to receive an exercise test for some reason. And the investigators defined 6 cardiorespiratory fitness groups listed as the columns here. 20th percentile, 40th percentile, 60th, 80th, 97th, and 98th percentile is extremely fit. The 98th percentile could do on average 14.5 METs, which is the equivalent of uphill mountain biking, whereas the least fit group had about 4.7 METs of peak activity, and that's pretty low. That's like walking flat. And when you look at the baseline characteristics, you can see that these are pretty typical people that we might see in clinic. Some of them have hypertension, some of them smoke, some of them are on statins and antihypertensives. And what the investigators found after 10 years of follow-up is 23% of patients died during that time. Those classified as extremely fit lived on average 6 years longer. The age of death was 79 versus 73 years. And these findings held true for all races, ages, and sexes. There was a 50% improvement in death relative risk for people in the low fit, so that's the 5 to 7 MET group, compared to the least fit, which is the less than 5 METs group. These findings also held true in sensitivity analysis, where the authors excluded people who were diagnosed with cancer, MI, strokes, congestive heart failure, had a PCI, or a CABG within 3 years of the exercise test. And I just want to highlight that these red bars show you where about a 50% relative risk reduction is achieved. And you can see, especially in the young group, simply going from least to low results in that 50% relative risk reduction. It's a very provocative figure from the same paper that basically compares each fitness group with each other and then also with comorbidities from the study. And you can see that being least fit confers a hazard ratio of 4 of all-cause death. And actually, even being fit compared to high fit has a higher, is associated with a higher hazard ratio of all-cause death than smoking. And so one thing we can take away from this is that being unfit is potentially as bad, or if not worse than doing something like smoking. So I know it's an observational study. What can we actually conclude about the causality here, right? Fitness obviously interacts with all of the comorbidities and also acts upon the outcome. There's many covariates also that probably are active here on the outcome variable that were not measured, like socioeconomic status and literacy. The study was also retrospective. It didn't study exercise, it studied fitness, and it may not represent the general population. These were people referred for an exercise test, presumably for some clinical reason. But I still think we can conclude that the findings strongly suggest, but do not prove, that fitness causally reduces mortality. How can we conclude this? Well, first of all, there was a huge effect size. There was a dose-dependent response. The findings are both internally consistent within the study after various sensitivity analyses, but also when you look at other similar studies, you find the same effect. And as we just discussed, there's a plausible mechanism. And also, crucially, the randomized controlled trials in this area support this mechanism. So for example, when you randomize patients to exercise, you see that their insulin sensitivity improves. Insulin sensitivity reduces diabetes risk, reduces mortality risk. And these epidemiologic tools are very important when we can only use observational data to make conclusions and try and make inferences about causal relationships. And very similar epidemiologic tools were used to show that smoking is causally related to lung cancer in the 1950s. So let's move from fitness and into exercise. A small amount of activity goes a long way. So this was a prospective cohort study of 400,000 Taiwanese individuals using a self-administered questionnaire about their activity, and they were followed for 8 years. And they were divided up into quintiles of exertion based on met hours per week. And I don't show the baseline characteristics here, but they were quite similar in the various exercise groups. And compared with individuals in the inactive group, those in the low volume activity group who exercised an average of 90 minutes per week, which equates to about 15 minutes per day, had a 14% reduced risk of all-cause mortality and a 3-year longer life expectancy. Every additional 15 minutes of daily exercise beyond the minimum of 15 minutes a day reduced all-cause mortality by a further 4%. This is a pretty old study from 1995 of 9,000 men aged 20 to 82 years who were either healthy or unhealthy, as deemed by the authors, and had preventive health visits and an exercise test at 2 of these visits, with an average duration between the exercise tests of about 5 years. And what you see here is that people who were unfit at both exercise tests had a higher association with all-cause death. People who went from unfit to fit had an improvement in that risk, and people who were fit at the beginning and remained fit at the end, as you might expect, had the lowest risk of death. And one of the important things here is that those that were unfit were people in the lowest quintile of fitness. Everyone else was considered fit, so even if you were low fitness, which is a very permissive definition of fitness. There's plenty of scientific statements on the impact of assessing VO2 and fitness and what the benefits might be. And this is just a summary of many of the key studies in this area that shows you that, in general, for every MET increase, you can expect that a group will receive some survival benefit from that ranges between 8 and somewhere between 8 and 30%. This is a pretty provocative study, though highly problematic, published in the British Medical Journal that compares exercise to medications for various cardiovascular diseases. So this was a study-level network meta-analysis of 16 meta-analyses containing 305 randomized controlled trials with 340,000 participants. And drug trials were mostly placebo-controlled, although some of them had some comparisons between 2 different drugs. And you can see that based on looking at patients in the various disease groups, looking at the effect of medications versus exercise, the odds ratio of all-cause death for these interventions is pretty similar. Now, this study has several flaws, including that because they're looking at many different studies, there are different populations of patients, there's high heterogeneity of exercise programs used. Exercise-treated patients were also on drug therapy for standard of care, and this may have mitigated the effect of exercise. And of course, this is a network meta-analysis, so none of these comparisons were directly made. We do know that adding exercise to the standard of care has an appreciable relative risk reduction in mortality. So this is a 2023 meta-analysis from a Danish group on 211 randomized trials comparing exercise and standard of care to standard of care in patients who had hypertension, diabetes, or cardiovascular disease. And you can see here that the addition of exercise generally comes with a fairly significant relative risk reduction. And also one interesting thing is that the follow-up durations are quite short. You can see that in the stroke follow-up group, the follow-up was a median of 3.6 months, suggesting that even a short amount of time of addition of exercise may have a benefit. Bringing this a little closer to the ASCVD world, this is a 2023 Norwegian study of 59 patients with coronary artery disease who underwent PCI with IVUS. And then patients were randomized to supervised high-intensity interval training versus standard of care. And then at the end of the 6-month period, they received a repeat IVUS and angio. And I just want you to look at the row that says TAV, which is total atherosclerotic plaque volume and measured in cubic millimeters. And you can see that there is a about an 8 cubic millimeter reduction in plaque in the HIIT group versus a 3 millimeter increase in plaque in the control group. And we can also see that when they measured VO2 max among these patients, that there was about a 3.5 milliliter per kilogram per minute increase in the VO2 max in the HIT group and about a 1.5 milliliter per kilogram per minute increase in the control group, suggesting that the HIIT intervention did improve exercise capacity more so than the control group. And you might wonder, well, do we care about total atherosclerotic plaque volume? Why does this matter? Well, in this landmark study by Mortensen in JACC of 24,000 symptomatic asymptomatic patients from a Danish heart registry who underwent CCTAs, we can see that really it's the total plaque volume measured by coronary artery calcium and not really the number of stenosed vessels that is related to your risk of developing an ASCVD event like an MI. The sad thing is that VO2 max is going to decline nonlinearly over the lifespan. So this is a study of individuals at pretty much all age ranges that underwent serial testing for peak oxygen consumption and included about 700 patients, both men and women. And you can see that over the lifespan with each passing decade, each passing decade after 40, there is a reduction in VO2. And on the right chart, you can see the rate of change of VO2, and you can see that it progresses over each decade. And it's also true that the higher someone's starting VO2 max is at any decade, probably the higher their VO2 max will be at later decades. And this is a really important concept in exercise and in longevity medicine, because many patients may say to you, well, I can do the things I want to do in life now. I don't want to win a cycling race. Why should I go cycling? And I think the point we should be making to these patients is that you can, open a jar of pickles now and you can go on a hike. But the idea is that will you be able to arrive to your 60s, 70s, and 80s and be able to do those things? And one intervention that may enable people to do something like that is to increase their VO2 max earlier in life. We also know that cardiorespiratory fitness augments cardiovascular risk assessment. So this is a study of 1,600 men aged 42 to 60 who did not have diabetes or ASCVD and who underwent VO2 testing. And after 16 years of follow-up, during which 300 patients died, VO2 max was assessed in this Cox proportional hazard model for association with death. And even when controlled for CRP, alcohol consumption, waist to hip ratio, family history of cardiovascular events, and exercise-induced ST changes, which I would say is a lot of adjustment for some very important things, you can see that even small amounts of improved VO2 max are strongly related to decreased risk of death. We also know that in people who have high CV risk assessment scores, that fitness or being unfit can reclassify those patients into different risk levels. So on the left, you can see patients with Euro score assessment, and on the right, you can see Framingham score assessment. And you can see that patients with high Euro scores or Framingham scores and who are also unfit have the worst survival risk, whereas patients with high scores who are fit have a vastly reduced risk. And so this is a set of bullet points from the AHA scientific statement on assessment of VO2 max, which basically concludes that the preponderance of evidence is so strong that cardiorespiratory fitness is a predictor of mortality, and maybe even more so than things like smoking and hypertension, that it really should be assessed at every visit. Efforts to improve cardiorespiratory fitness should become a part of clinical encounters and be accepted as a vital sign. And it goes on to even recommend that we should be assessing cardiorespiratory fitness either by objective means, like doing a VO2 test or an exercise ECG, or at least by less objective means, like by using risk calculators, VO2 max calculators that basically involve patients inputting how much exercise they do and how hard it is. Obviously, there are different levels of accuracy of these two kinds of tests. But I would say that more data is really needed on the utility of assessment of cardiorespiratory fitness in clinic. Does it actually improve fitness or outcomes? So we're going to leave behind cardiorespiratory fitness for a second and start talking about strength. And I think strength is kind of the forgotten pillar of fitness and exercise. Just like cardiorespiratory fitness, low muscle mass and strength can increase mortality risk. So you can see here that in this study of 5,000 participants that were age 50 and older from the NHANES registry who got DEXA scans and knee extensor strength tests, found that patients who have adjusted low muscle mass, or LMM, or low muscle strength have a pretty substantial increased risk of all-cause mortality. And we can see that this association holds regardless of physical activity. So in patients who have low muscle mass and who exercise, some of the risk is reduced, and they do better with patients who don't exercise and have low muscle mass, but it's not completely reduced. And the same is true in the low muscle strength category. We also know that like VO2 max, lean mass decreases with age, and this is known as sarcopenia. And you can see in this 2021 cross-sectional study of 2,000 participants using labeled water to assess muscle mass, that muscle mass progressively decreases with age. On the left, you can see females, and on the right, you see males. We also know that while you can add muscle mass at all decades of life with resistance training, it is harder to add muscle at older age compared to younger age, and this is known as anabolic resistance. And this is simply to show you that muscle protein synthesis after resistance training is blunted using similar resistance training stimuli in older versus younger subjects. So let's talk about training. How can we ameliorate or improve all of these inevitable declines in our fitness? So is it ever too late to start training? This is an N=1 study of a 101-year-old who held the record for 1 hour cycling distance of 25 kilometers, but of course that was not good enough for him. So for 2 years, he trained for 1,200 miles on a bike and did 80% of this work at a light intensity, according to him, and 20% at a hard intensity. And he managed to increase his VO2 max from 31 to 35 milliliters per kilogram per minute, which is astounding just in and of itself, but then also to have a 101-year-old with a VO2 max of 31 is extremely impressive. And here's a study with more subjects in it. This is an observational study of older adults, 2 different cohorts, one that was largely sedentary and one called GiroFit, which is a cohort of US veterans who underwent a supervised exercise program 3 days a week. And I know there's a lot of different graphs on this slide, but essentially the upshot is that the patients in the GiroFit group could generally do better on a 6-minute walk, rise from a chair more often in a 30-second period, and took less time to do the get up and go challenge. And you can see on the right-hand side of this slide that these effects hold true for all age ranges as well. This is a study looking at cardiorespiratory training. So in this study, even just 3 weeks of 70% VO2 max cycling increases cardiorespiratory fitness. So the 2 lines you see here are of are assessing cardiorespiratory fitness in 8 older men and 8 younger sedentary men of a mean of 68 years and 23 years respectively. And you can see that after undergoing cycling 3 times per week for 45 minutes, that both groups have a very substantial increase in their VO2 max. And the other thing to highlight is that even just after 3 weeks, you see this improvement. And we actually don't know how long this would go on because we don't have that data, and whether or not an upper limit to this occurs. We all want to know, what is the minimum effective dose of exercise training that I can do to receive a benefit? And when we talk about dose and exercise, we're talking about intensity, duration, and frequency of training. And this, again, are some conclusions from looking at over 49 different studies, which obviously we don't have time to go through, on changes in cardiorespiratory fitness based on training. And essentially the top line conclusions from review of these studies that the authors found in the scientific statement were that when performed frequently over weeks or months, a wide variety of endurance type physical activity regimens produce clinically significant increases in cardiorespiratory fitness, such as greater than 1 MET. And in general, the intensity matters more than the frequency or duration of exercise for improving CRF. We also want to know, is high or medium intensity better? And I would say that there are controlled trials that go both ways on this topic. It's possible that HIIT, or high intensity interval training, improves cardiorespiratory fitness more than moderate intensity, but that there may be some disadvantage, especially in patients who are coming from sedentary to exercise training, and that they may injure themselves a little more so when starting HIIT training, rendering the effect a little bit ameliorated. We also know that adding resistance training to aerobic training complements the benefits from aerobic training. So you can see here on the left-hand side of this table that either format of training has benefits for each comorbidity related to all-cause death. So something like glycemic control is more enhanced by aerobic training than resistance training, but doing both of them together has an additive effect. So what really is resistance training? It's actually a multitude of different things. So it can be anything from body weight exercises, doing air squats or lunges, to using a resistance band, to lifting a dumbbell or a barbell. And I think that when patients hear strength training and they hear lifting weights, they think of this guy in the Olympics doing a clean on this very heavy barbell, and might say to themselves, I don't want to do that. I can't do that. That sounds like it's going to injure me. And I think it's our job to remind patients that this is not necessarily the picture of strength training. It can also involve a resistance band. So what is the dose of resistance training we should be recommending to patients? So most patients would benefit from a moderate intensity resistance training recommendation, which includes working at a weight of about 40 to 60% of the 1 rep max. The 1 rep max is really just what is the maximum weight you can put up for a single rep. And I don't know that we should be advising patients to go and try and put up a 1 rep max to figure out what weight they should be working at. We could see how that would go poorly. But this is more of just a guidance of how heavy should something be. And they should do this for about 8 to 12 reps, about 2 days per week. And we should also know that resistance training really is for everyone. It's for younger people, for older people. There are even some studies looking at resistance training in children and that show improvement in their ability to exercise. And the other thing that I learned from this is that in general, we should be recommending that patients use all of their muscle groups as opposed to doing multiple sets and targeting one muscle group. And this is because most of the benefit seen in resistance training occurs in the first set. So what is the optimal amount of time to do resistance training? There's not as many studies on this as in the aerobic activity side of things, but we think that a maximum benefit for most people probably occurs between 40 and 60 minutes of resistance training per week. And this is in both all-cause mortality and cardiovascular death endpoint. What's kind of interesting about this is why does doing more tend to normalize the relative risk and then eventually also actually increase your relative risk of these things? I think this is something that should be further studied. We also know from doing from this meta-analysis that resistance training can indeed increase strength, which I know seems obvious to most of us in here, but I think it's worth just making sure that we actually have, a possible mechanism for how we might impact someone's ability to do things in the world. And it also decreases visceral fat mass. This is another meta-analysis that looks at DEXA scans in people receiving resistance training, and you can see that there is a pretty consistent effect that strength training can decrease visceral fat mass. So if exercise is for everyone, do we need to worry about certain patients before they initiate exercise? Very few patients need to be screened before they begin exercise. So in general, patients younger than 45 or for men or 55 for women who are asymptomatic and don't have a family history of sudden cardiac death or uncontrolled risk factors don't need any additional screening. Patients who are above this age range and intending on vigorous exercise who do have some risk factors or a strong family history should undergo history, physical, and biochemical testing. And then some patients will, of course, need further testing after that, which may include supervised exercise tests. And then it gets a little more complicated with patients who've had a history of sudden cardiac death, who have ICDs, who have adult congenital heart disease, genetic cardiomyopathies, heart failure, aortopathies, obstructive cardiomyopathy. Most patients will still benefit from exercise, but may require just a little bit of a tailored risk-benefit discussion and perhaps some supervision on initiation of exercise. There are very few absolute contraindications to exercise and resistance training. You can see that a lot of these are quite bad and are quite obvious that we shouldn't be recommending someone necessarily go to the gym, like unstable coronary artery disease, decompensated heart failure. Although, of course, Tomio gave his gram rounds. Patients, supported on LVAD can go and do resistance training, right? So I think just remembering that things have to be pretty bad for you to recommend avoidance of exercise. Okay, so what is the exercise prescription we should give to patients? So after reviewing all of this, I think that this is a pretty generalizable exercise prescription that we can be comfortable with. So I usually tell patients to do at a minimum 150 minutes of exercise per week. And this is consistent with the amount of exercise you've seen in the studies I've presented here. It's usually about 150 minutes per week. And they can divide this into 5 30-minute sessions or 3 50-minute sessions. I think either of these are fine. There's probably some benefit to doing exercise every day, but there's also probably some benefit to doing a little bit of a longer session. I would say, though, that the optimal lifespan and health span benefit could probably be achieved with daily exercise with no upper limit in the benefit for most people. There are some studies looking at, ultra marathoners and people who are fasting for a long time and doing double, triple Ironmans, things like that, that may have some health consequences, but I think that's generally outside the scope of clinical practice for most of our patients. And then I usually recommend that training have quite a bit of variety and consists of the following. So VO2 max training, which is very vigorous and I think is the most potent stimulator of improving cardiorespiratory fitness, about once per week. Other aerobic training about 2 to 3 times per week, and then resistance training. I put 2 to 3 days, but could be 1 to 2 days based on that scientific summary statement. And then I also put stability in here, even though we didn't talk about it, which something that may become important later in life in terms of maintaining balance, not falling, and so on. I usually suggest patients track their progress. I mean, we tell patients to take their blood pressures and write them down and show them to us. And I think the same should be true of what they're doing in their gym or their daily lives. And then making a concrete plan with patients about what they're going to do, how long are they going to do it, and how often are they going to repeat it. Patients, of course, don't measure their VO2 when they're exercising. So we have to be very concrete when we tell them what these things actually are. So VO2 max training usually consists of 45 to 120 minutes of exercise once or twice per week with an adequate warm-up and 4 to 5 approaching VO2 intervals. About 3 to 8 minutes per interval at about 90% of the maximum heart rate. And importantly, this is a type of training that includes work sets and rest sets in order to sort of recover and be able to do another near VO2 max set. And that comes usually in a 1-to-1 ratio. Aerobic training, on the other hand, is about 45 to 90 minutes per session in general, about 3 hours per week, and at 70 to 75% of the maximum heart rate or VO2 max, and is typically steady state, and recommending patients do not take rest breaks during this type of training. Resistance training, about 15 to 60 minutes per session, 2 to 3 times per week, and generally recommend a mixture of high repetition, low weight exercises and low repetition, high weight exercises, since the former really stimulates the generation of muscle mass, whereas the latter stimulates muscle strength. So what should it feel like to patients? VO2 max training does not feel good. It's not a sprint. It's something that you can do for 3 to 8 minutes, but it feels like you must concentrate all of your physical and mental energy on getting through an interval and wondering when it's going to be over. And at the end of such intervals, as we know from CPET testing that we perform, patients should experience lactic acid buildup and muscle burning. Aerobic training feels more like I could do this all day. I could talk and have a conversation, but I would rather not. and muscular fatigue is in general quite low for this kind of training. And then resistance training should feel pretty difficult in the final few reps, and really require focus to move the weight in a safe manner, especially with regard to strength training. So patients often have various excuses for why they don't exercise, and I try to push back on all of them because I think all of them are surmountable. So the first one is it's too cold outside, or I travel a lot and I don't live near a gym. So if it's too cold, I suggest getting a gym membership or perhaps working out in your living room. If you're traveling, you can buy resistance bands and take them with you. And there's also plenty of apps that show you a ton of very creative body weight exercises that really allow you to exercise anywhere. The next one is it's boring. I agree. I don't like exercising either, but I usually suggest patients couple exercise with something more fun, like listening to a book or watching a TV show. And I actually know patients who tell themselves, I don't let myself watch TV unless I'm exercising, and that tends to work. A lot of patients will say, well, my Apple Watch says I take 10,000 steps, like I already exercise. And while very short bouts of exercise have been shown to be beneficial, in general, taking 10,000 incidental steps while you're, walking around a grocery store is a bit different than actually setting out and performing a discrete exercise episode. Patients often say, I don't have time, I have a kid at home. And what I would say is that even very short amounts of exercise, like 7 minutes of HIIT training, have benefits. Try and split childcare with your partner so that each of you can get a 7-minute exercise episode in. And then some patients will say, why do I need to exercise? I don't need to lose weight. And we should remind those patients that the benefits of exercise extend well, well beyond weight loss and body composition. So in conclusion, longevity medicine targets both lifespan and health span in both healthy and unhealthy individuals. Aging results in functional decline, including progressive decrease in cardiorespiratory fitness and sarcopenia. Low cardiorespiratory fitness and strength directly reduce quality of life because they limit what you can do, and they associate with all-cause death and cause-specific mortality. Exercise is the most potent intervention to improve fitness and strength. Low cardiorespiratory fitness and being sedentary have a higher risk of all-cause mortality than many traditional risk factors, and they also reclassify cardiovascular disease risk. Nearly 80% of Americans inadequately exercise. Cardiorespiratory fitness can be thought of as a clinical vital sign, and it should be assessed in clinic, either using objective means or by a non-clinical assessment tool. A complete exercise prescription includes both cardiorespiratory and resistance training. Improving from the least fit category to even a low fit category is associated with a very large improvement in the risk of all-cause death. It's never too late to start training. There's no upper limit of benefit for most people, again, with those caveats aside. And we should assess at-risk patients for contraindications to exercise, but we should always permit maximally safe exercise and relieve restrictions as soon as possible. Some things that we didn't discuss are things like understanding how cardiorespiratory fitness assessment changes outcome. Assessment of whether or not including cardiorespiratory fitness in our risk calculators may improve assessments and also improve outcomes. There's a really known potent effect of socioeconomic status, literacy, race, ethnicity, and physical disability on the inability to perform exercise. And so public health initiatives that treat inability to do exercise, such as like an exercise desert, similar to how we treat food deserts to make community-based interventions and allow people to perform exercise, are really important. We also didn't discuss the role of activity trackers, which are kind of rampant now. Caffeine, music, other motivational methods to improve the amount of work someone does when they set out to do exercise, and also the role of supervision of exercise and prescription of exactly which exercises to do and when, which I think are hugely beneficial for a lot of patients so they don't sort of waste time at the gym. We also didn't talk about the role of nutrition in supporting training, including of daily protein intake. And one of the things in this space that is most provocative and most interesting to me is, are there any small molecules that can simulate exercise or otherwise increase longevity? And we actually have one of the most important labs in this space at the University of Washington. It's the Caberline lab. And this lab is studying essentially the clinical effect of giving rapamycin to dogs to try and extend their lifespan. You can imagine there is no shortage of people willing to sign up their dogs to enroll in these studies, and is a very promising avenue for research. And I just want to make one acknowledgement to someone who has kind of strongly motivated me to dig deeper into longevity medicine. I know many of you are familiar with Peter Attia, who is someone who trained as a surgeon at Hopkins, but then decided he wanted to dedicate his life to preventive and longevity medicine. Many of you may find him very controversial, and that's certainly founded. There are some recommendations like maybe getting coronary artery calcium scores or CCTAs on all patients to look for ASCVD. That may be very controversial and not economically feasible. But I do think that what Peter brings to the world is that he has shown us how we can look at longevity medicine through a very scientific lens. And I think this will bring about a new renaissance in this space. So I'll just leave you with one thing. This is a very beautiful couch, but don't sit on it. And and maybe one day, like alcohol, couches will contain black box warnings that say sitting may cause premature death and disability. Thank you very much.
That was a absolutely fantastic talk given by somebody who clearly feels deeply and knows this literature incredibly well. Thank you. We'll open for questions. Please use the microphones. People at home, please put your questions into the Q&A box.
Elliot, that was wonderful. I've always admired how you've been able to weave this into your practice throughout fellowship. You always know an Elliot Stein cath report when it's a cath report that highlights sleep hygiene after your DAPT recommendation. But to go earlier in your talk, you talked about how the amount of time that doctors and primary care physicians are able to spend on this. Apart from having an exercise prescription, as cardiologists, what has been your practice, or what do you take away as what we should be doing at the end of our visit? Is it, trying to carve out more time, more frequent visits, or is this a space that needs to expand and have the help of our primary care colleagues to implement some of these recommendations, and how do we move forward to some progress?
That's a really excellent question. And I mean, I'm in ACHD clinic now. We generally see patients once a year, and it's not sufficient to keep tabs on them. And the other thing is to recognize that this may be if you see a patient once a year, it may be the one time per year that they actually talk about exercise with someone. So I think, the strategies you mentioned are really good ones, and encouraging primary care colleagues to do some of this with us, but also using some of the tools that have come online for us to look at. Just like the advent of home blood pressure monitoring allowed us to check in on a patient's blood pressure when we can't see them. If you look down, tons of your patients have Apple Watches and Garmins and things like that. And I think just taking a deeper look at the data they have on their watch and saying like, hey, I want you in a month, when you send me your blood pressures, I want you to also send me, your Apple Watch estimated VO2 max, which is actually quite accurate. And keeping tabs that way. Because obviously, I don't think our system can tolerate, seeing patients 4 times a year just to make sure that they're exercising.
That was an outstanding talk, Elliot. So why did Dr. Krieger get snacks and we never got snacks at this side? But that is not the question. Can you comment about if you think that us giving prescriptions for exercise, because the patients are always craving for that, would make them more actually adherent to medications? Because we have the perception that we're just, my patients are always complaining, oh, you're just putting pressure on me, take more pills, more pills. So is there a literature on that? And could actually help us in when, especially if we're doing prevention and we see patients for a long time, if they know that we've talked about exercise and lifestyle changes, and then we say, well, look, this medication is important, and maybe they would take us more seriously or be more compliant.
Yeah, I mean, I think I think if you have a patient in front of you who's reluctant to take a medication, and there's really no hope of them taking it, then saying something like, well, you can at least reduce your risk in this way and make an exercise prescription. Are there studies on this? I don't think so, but based on the ones I showed that show that exercise may have kind of an equivalent effect as some drugs do for certain disease states is really promising for safely making that recommendation.
We probably have time for just one more. Dr. Bennett?
Elliot, that was awesome. Did you come across anything in terms of timing of day? I've had a couple patients ask me this recently. I think the most important thing is to do something, but for people trying to fine tune and really focus on longevity, anything about that?
Absolutely. I think that's a really good question. There is not strong evidence for time of day. I would say that there are different chronotypes people have, meaning there are different times of day people feel most energetic and willing to exercise. I think we all know this about ourselves. And I would say that patients should probably just go with what their chronotype is. If they're most motivated in the afternoon, they'll do better in the gym in the afternoon. They'll also lift weights safer. And yeah, I think further study would need to be done in that field.
Thank you so much. That was outstanding.